Great, welcome back everybody. Whenever you're ready, Jazz, you can start and I'll keep an eye on the questions again, and I can admit people. And Naomi, if you're there, there's a few questions I think you can probably answer directly in the chat that I wasn't completely sure about. Thanks.
Okay. Hi. Hi, everyone. My name is Jaspreet. You can call me Jazz. I'm currently working at St. George's Hospital, and I'll try to give you a few tips in terms of what I find useful in terms of my application. What I'd like to start by saying is I know it's scary. It's really, really scary. It took me almost 3 years to finally get the courage to start my application, even though I kept saying to everyone I want to do this application. And I think the one thing that tipped me over is looking at someone else's application face to face, because until you see someone else's application, getting all this advice seems very far away from you. It almost feels vague, like it's in space. But when you actually see someone's application face to face, physically, it suddenly all makes sense and it looks so simple. It looks like it's actually achievable. So I felt that I collected so much evidence, but I just didn't know if it was enough. And then I looked at my colleague's application who had just submitted and received her successful outcome. And when I looked at it, I'm like, oh my gosh, this is so simple. But the difference between me and her was she was previously a trainee, left training, and then went into the portfolio application. So her thinking process was very different. And it's the kind of thinking we need to have. We need to think like the trainees. And if you think like a trainee, you'll realize you don't actually need as much as we keep thinking we need. You already have all of it. It's just simplifying your life, which we, I think, as IMGs find very difficult to do. We overthink things. We focus on quantity versus quality or both, but we basically want to give a lot more than you actually need to give. So try to make it as simple as you can and try to look at someone else's application to help you filter and believe in yourself. Okay, so what am I going to talk about today? I'm going to talk about two HLOs, HLO 5 and 6. And the reason why we decided to focus on these two is because we felt that a lot of people have the evidence for these two domains or these two HLOs, but don't know they have it and therefore struggle with deciding what to present in these HLOs. In terms of amount of evidence you need, so when you look at this diagram from the GMC website, it tells you that HLO5 is only 5% of your total evidence base, while HLO6 is about 8.3%. So if you look at this, 5% of about 120 documents, you'll have about 5 or 6 documents in total. 8.3% of 120 documents, again, will be about 9 or 12. So you actually don't need a lot of evidence for these domains. And it's about making it very concise and making sure you capture what they want to see. Don't put too much evidence, just keep it very specific to what they want. Those are two guidance documents that Naomi's already talked about. So the SSG guidance from GMC for pediatrics, and then the Royal College pediatrics curriculum. I think one of the things Naomi has already mentioned is that they don't always map onto one another. So it can get quite confusing because when you look at the Royal College pediatrics curriculum and just look at the HLOs, how you're actually going to put the evidence into the GMC website can be quite different. So try to focus on more on how the application is structured in terms of what Naomi's already presented on the GMC application form when you're grouping your evidence right from the beginning. This is again extracted from the SSG from GMC, which looks at the HLO5, health promotion, illness prevention. This is what they recommend you should know in terms of your knowledge, skills, and experience and what kind of evidence you should present. We'll look at this in a bit more detail. And then this is the Royal College curriculum in terms of what they think you should cover in that HLO and what you should, they've given you specific examples. Again, these examples are quite interesting. What I found useful is I printed both of these guidances, sat with them before I started my application and ticked what I felt is easily achievable, what examples I can use in each particular domain or HLO, and then put those examples in writing. So I knew that when I would see these examples, either I'd seen them retrospectively or I'd see them prospectively. I already knew I had to collect that evidence and put it into the folder that I already created. So it helps to actually just sit with these documents and go through them before you even start the whole process to know what is easily achievable, what will you have to work or go out of your normal day-to-day routine to try and collect. Now, if you look about health promotion, I want you to think broadly. This is how I think you can make your life easier. Look at it in terms of topics you think cover health promotion. Don't only focus on what's been provided in those two guidance documents. Think broadly. These are simple things that you do on a day-to-day basis. I'm sure all of you deal with vaccination at one point or another. One of the questions every pediatrician asks is, are your children up to date with vaccination? That is already one tick box in your health promotion because all of you will have talked about vaccination at some point. Vitamin K, if you've done neonates, at some point you will have talked about children who have not got vitamin K injection or have chosen the oral vitamin K over the I am vitamin K. That's health promotion. You're trying to encourage parents to get vitamin K, and what is the reason behind it? It could be a discussion you've had with the parents that you've documented on your hospital system. It could be a health information or vitamin K leaflet you've shared with the parents. Whatever you've done can be evidence in the health promotion area. Breastfeeding. Everyone has dealt with breastfeeding, whether it's in the neonatal rotation, whether it's in the community rotation. You will all have dealt with breastfeeding. When you're explaining the benefits of breastfeeding, or you're explaining the benefits of giving express milks to mothers who have preterm babies and cannot express at that point. All those things are all categories of health promotion. But those discussions you have, how you're going to show them. Is it through the notes that you wrote? Is it through the discharge summary that you wrote? You can decide how you're going to present it, but you've all done this. This is something that every pediatrician in training does. Dental hygiene. Again, this will depend on which rotation you're doing, but most pediatricians will ask about, are you registered with a dentist? Or you'll examine the teeth at some point. You could be doing an examination of the throat, and then you see, oh gosh, you've got plaque on your teeth, and you've given some advice. These are basic things you do. So think about basic things you do. Don't think too far. Think about what you do on a day-to-day basis, and you'll be able to get all your evidence. Diet. All of you will cover diet, whether you'll all take oxology measurements of each and every child you see, and you'll always plot them. So just by plotting them and looking at their trend and growth, you've already ticked box that exercise, because you've talked about the importance of whether they're growing according to their centiles, whether they're dropping weights, whether they're crossing across centiles too fast. Then you'll talk about things like picking up signs of overweight or excessive weight. You'll talk about eating disorders. You'll talk about children who are underweight or malnourished. You'll talk about failure to thrive. All those categories are health promotion. So either you've referred them to a dietitian, or so again, referral letter could be used to show health promotion. So this is where cross-referencing occurs. If you talk just about weight, you can cross-reference this with several things. You'll first, if you've identified a child with failure to thrive or an eating disorder, you'll refer to it as another specialty, either an eating disorder service, or you'll admit them to the ward, or you will refer to a multidisciplinary team, a feeding team. Whichever way you've done it, a referral letter will not only act as evidence for your health promotion domain, it will also act as evidence for your communication domain or team working domain. So this is where Naomi was talking about cross-referencing. You've looked at one area, which you've identified as the area you want to focus on, weight of the child and how it's a concern. And then through the evidence you've used to show how you've dealt with that particular domain of health promotion, you can cross-reference it to other areas of your HLOs. And we talk, most common is, like I've said, communication and multidisciplinary team working. Sexual health, again, this is something that you've all covered at some point. More commonly, when you're doing a health assessment of children who are much older or in the adolescent age and you admit to the ward, how do you promote their sexual health? It could be simple things like, have you asked about what they'd like to be identified as? And how do you promote them to be able to accept that or help their family accept that? You've talked about how do they protect themselves if they declare they're sexually active? How have you given them promotion? How have you assured that they're doing it in a safe way? Those are basic things you'll do in most cases where you do health assessment of adolescents. Online safety. You may talk to them about, again, the health assessment. What do you like doing? What are your interests? How do you show that they're being safe in whatever interest they have? Everyone talks about TikTok. Everyone talks about Instagram. Everyone is online nowadays. So these are discussions you'll have regularly with your young people, especially when they're admitted to the ward. How do you ensure that they're keeping safe? That's a way of health promotion. PPEs and hand washing. Again, this is something you do day to day. You could do simple things like, for example, you could ask, can I help design a poster for hand washing or on PPE? Can I help give a talk to staff about the importance of hand washing, and then give that as evidence of health promotion. Sleep difficulties. Again, this is something almost all of us cover. You could discuss things like a prescription that you've done for sleep difficulties, given melatonin. That will cross-reference not only for health promotion, it will also cross-reference for patient safety in terms of prescriptions, because you have to give them information about how do you give the melatonin, when do you give it, what are the possible side effects. So again, you've cross-referenced two areas with a simple thing such as sleep difficulties discussions. Medication compliance. I think Naomi mentioned something about a WEAS plan. When you're discussing a WEAS plan, it's not only about communication, it's also about health promotion, because you're trying to encourage this child to have control over the control of their asthma. And how you're giving that, that's health promotion. It could be through making sure that they share the plan with the school, making sure they keep a plan at home, making sure they have an inhaler at home and at school. So there's several aspects you've covered through that, because you're not only communicating with a child, you're communicating with another agency outside the home environment, which is school. So again, it's not just about health promotion. You've covered communication with external agencies. You've talked about communication with the family and the parent. Substance misuse. Again, when you're doing the health assessment, this is a lot of things you cover in terms of substance misuse. encouraging parents to stop smoking or encouraging parents to stop taking things that could be harmful to their children is a way of promoting health not only for the parents but also for their children. Talking about things like if you're attending CPDs on things like how to reduce carbon footprint, or you're engaging in a role in the Royal College as part of that committee in terms of reducing carbon footprint or smoking pollution, all those things. If you're part of that kind of committee, those meetings that you're attending, or those campaigns that you're attending, or posters that you're producing, all those things can promote towards your evidence in health promotion. And then I can't see my own screen, but I can't see the last thing. I'm going to try and move this so I can see what I'm actually presenting. Vitamins, yes. So again, when you're looking at children, vitamin D and multivitamins in children under 5. So this is more common and probably a more common practice when you're doing community pediatrics, where you'll ask every child under 5, you'll advocate for every child under 5 to have multivitamins. When just through that discussion or encouraging them to get that is part of your health promotion. Vitamin D, ideally, we should encourage every child to have vitamin D, especially during the cold winter seasons. This could be in your ED discussions when you're just taking your regular when you're taking your regular history. It could be part of your regular history so that you're always covering it as part of your health promotion. So I think one of the ways you can capture some of these things is when you're creating your template of history taking in whatever pediatric setting you're in, try to put this as part of your regular intake, things like sexual health, vitamin D, dentist, immunization. If you put this as your regular history taking domains, you'll always have something you can use as your health promotion evidence. Housing. When you see children, especially if there's a one parent who's suffered domestic abuse and they're struggling with housing, and you maybe have written a letter to housing because mother's told you, actually, there's mold in my house and my child's asthma is not being well controlled and I need support with that. You've written a letter to the housing department asking for advice on how we can support this family, or you've given mother some advice on how she can prevent mold in the interim while waiting for the housing team to address her or support her with the mold in the house. That's all health promotion. Most of this way through your communication or your notes, written notes that you can act as evidence, or a letter that you've made to the housing department, which you can use as evidence. Again, this is cross-referencing because any referral letter, whether it's to a medical agency or health agency or non-health agency, will contribute towards your evidence for communication domain. Culture, when you've talked about things like, I think I'll give this example from the community pediatrics. When we talk about giving a diagnosis of ASD or ADHD, more commonly ASD than ADHD, there are certain cultures who would prefer not to give that label, like we in quotes, to their child because they find it very difficult to explain that to their cultural society. My society is one of those. I actually have a relative or a nephew who has a diagnosis of ASD, but my aunt will not say that out aloud because she knows the minute she says that, the people around us or our family will not accept it. And I can totally understand it, but I can see when I meet this child that he definitely has a diagnosis of ASD. But it's very difficult to overcome that barrier. So sometimes when you see a child in a clinic and mother refuses to get genetic testing or she refuses to get an assessment for ASD, document the discussions that you have because you have to be aware that you can't push them into getting that assessment, but document the discussions. Why were they reluctant to have it? Why were they reluctant to have that assessment? Try to be empathetic. And that discussion that you have with the parents and the child is very important in terms of showing that you actually did take into account the culture of that child, but also you try to help them understand why you think it's important to have that diagnosis. How does it promote the health of that particular child? So that's a very good example of documentation they can use for health promotion. Again, religion is a similar thing. There could be certain religions that don't allow certain or would not advocate for certain things that we take for granted. I can't give an example in terms of community pediatrics, but I'm sure you all have very many examples that you can think about. Try to document any discussions you have that try to help you explain to the parent why you think it's important for them to get that particular intervention, but also be accommodating to the fact that you do understand why they're not able to accept at that point and whether they can reconsider in the future. Language barriers. You'll use this everywhere. Whatever setting you're in pediatrics, you will have some language barriers. And how do you accommodate those language barriers? Is it are you using Makaton? Are you using interpreter? Using those services shows that you're promoting the health of that particular child and the family. Because if you weren't using those services, you wouldn't be able to accommodate the differences in that. You wouldn't be able to communicate whatever you're trying to communicate effectively to that family, and therefore you would not achieve the outcome that you want in terms of promoting their health. Neurodiversity. If you meet a child with any sort of neurodiversity, whether it's ASD or ADHD, how do you adapt the environment around you to help help meet that child's health needs. I think a simple example would be a child comes severely constipated, or at least that's what you think. They come in with pain. So the child is just screaming and has a background diagnosis of ASD. The mom tells you, I don't know what's wrong with my child, but he's just screaming. And I'm giving you this an example from a child I actually dealt with in ED. So you can't examine this child because this child will not allow you anywhere near him. You get a very limited history, but it's something pointing towards, it sounds like it maybe constipation, but you're not sure because you can't examine the child. What do you do? How do you accommodate it? Because likelihood is this child is probably fecally impacted, but you can't really examine him. You're not getting a very clear history. What do you do? So there are two ways you can deal with it. Either you can just give medication and do a trial, or you could be invasive and do an X-ray to get your confirmation of the diagnosis. But again, that's not in the best interest of the child. So what's the best way to do it? So what we did is we gave medication to try, and actually we gave a quick laxative, which seemed to make some difference immediately in the ED, and we knew that that's probably what we're dealing with. So again, that whole reflection on that case, how you dealt with making a diagnosis in a child you weren't able to physically examine or get a full history on, shows your awareness of health promotion when dealing with a child with neurodiversity. Dealing with a child with ACEs, so adverse childhood experience. If a child comes to you with, for example, a history of um, any sort of adverse childhood experience. It could be sexual abuse, it could be domestic violence, and they're very traumatized and they've come into an ED setting, which is very overwhelming, and they just can't handle it. How do you accommodate them? Do you give them a separate room with someone that they trust, or do you give them something to distract them? All that's looking at health promotion. So again, it's very looking for examples out of the box. How are you promoting this health by accommodating the environment for them? I think that I've given a lot of examples. So I think by giving those examples, what I'm trying to show you is you have to think out of the box. Don't just stick to what's been given in the examples from the Royal College curriculum or from the GMC website. You need to think broadly. You're all doing a lot of health promotion on a day-to-day basis, and it's not something you're doing out of your day-to-day day-to-day practice. It's things you're doing every day without even thinking about it. It's just about how do you present that? How do you put that in writing? And because you document everything you do, you'll be amazed how much evidence you already have without even thinking about it. So what kind of evidence am I talking about? Clinic letters or referral letters? I've already mentioned that. Letters to external agencies. So I've talked about maybe a WEES plan being shared with school or a letter to housing, records of conversations with parents and patients. Um, Again, this is something either if your hospital has an electronic system, this is all being recorded day to day. You just have to basically download it and redact it. Reflections. It could be your own reflections on what you've discussed. A reflection on, I gave an example of the ASD patient who doesn't, mother doesn't want a diagnosis because she doesn't want, she's worried about what the society will think of her child. Do a reflection. Do a reflection on how you felt about it. The fact that you couldn't really push this child to get an assessment, even though you felt it was in their best interest because there were cultural barriers to it. Do a reflection on it to show that you actually understand what are the barriers to some children getting the health interventions that they require. Leaflets, it could be patient leaflets on several health promotion activities: importance of breastfeeding, importance of multivitamins, vitamin D supplementation, dental hygiene, presentation in and outside health. So it could be presentations about the importance of recognizing neurodiversity in school environments. So you could go to school to give it a talk about importance of recognizes early features of ASD, early features of ADHD, or importance of promoting dental health in within the school environment, importance of immunization, nasal flu vaccine in the school environment. All these are presentations that you can ask to give within the school environment or even outside in other areas. You just need to think a bit broadly. Quips and audits. It could be a simple audit like how many of our doctors actually ask about immunization history in their documentation? How many of our doctors ask about dental hygiene in their day-to-day history? So do a quick audit that basically could take you 2 or 3 days because you're just looking at pediatric history is taken over 2 days and you've already got an audit in place, and then give recommendations. Or you could get a quip from something like that, where you're giving simple recommendations like only 10% of us ask if our child is registered with a dentist when we're taking our routine history. How do we improve on that? We make it a standard practice that every child that comes into ED should be asked about registration with a dentist. So this is a quip that you've done. You've not only satisfied health promotion, you've satisfied your clinical governance HLO. So again, simple, but I think we just make things a lot more complicated when we're actually in the middle of this application. It could be other clinical governance activities. For example, making sure that we plot every child's measurements we take on a growth chart, whether it could be electronic, it could be their personal healthcare record. So that's showing health promotion because you're seeing that you're actually monitoring the growth of that child every time that child is seen by a health professional within your hospital environment. CPDs, you could do CPDs, but remember, it's not just doing the CPD and getting a certificate. You have to have done a reflection to make it effective. So do the reflection as soon as you can after attending the CPD. I got two examples from you, which are free. All of them are Go and Training and the Healthy Child Program, both available on the ELF website. So again, they're not things you pay for. They're simple to do. Do them, get a reflection. You've done your health promotion, CPDs. Health Education England Health Promotion Toolkit. There is regular courses. I don't know if they're still being run, but they're free courses that are run by Royal College on this particular toolkit. Very useful, and it helps you tick the domain for health promotion. Get testimonials. If you've done any type of leaflets, if you've done any type of working with care groups, like for example the SCN team or the Children Looked After team or the Community Pediatrics team or any other agencies, get testimonials from them about work you've done to promote health of children in that particular trust. HLO6, we're looking at leadership and team working. Again, most of us will think, oh gosh, I don't have a leadership role. I can't demonstrate this. You can all do it because you're all doing some sort of leadership on your day-to-day basis. Again, just think at a basic level. Don't think too hard. Don't think about having titles to it. You're all leaders without titles. And you'll realize that you all have some level of leadership. You just don't realize you're doing it. So I'll give you some examples. This is, again, just from the Royal College and website where you can get example, but I'd like you to think a bit more broadly again. There's clinical leadership. You're all leaders in your day-to-day work, whether it's leading a junior colleague, whether it's leading a ward round on a day-to-day basis, whether it's really leading a ED shift in the evening, you're leading. That's leading. That's clinical leadership. How do you show that? You could get an assessment, a work-based assessment, for example, ACAT, you get leader assessment, or you could just document your notes that actually on that particular date, I reviewed this patient that was seen by this junior colleague, and this was my add-on to the plan, or this is my edit to the plan. Just that documentation shows your leadership skills. Rota management. We don't all get a chance to do rota management, and at least in my case, it was done more by the trainees than by non-trainees. But it could be a different rota. Be creative. For example, you could say, I'm doing a teaching rota, or I'm doing a CP medical rota, or I'm doing I don't know, a journal club rota. So it doesn't have to be the rota that we all think about. It can be others. Look for other things that all of you are rotating in and do a rota on that. So take an initiative to do things that you may not have access to as a non-trainee, but be creative. Non-clinical roles. So for me, I was quite lucky because I got to be an SAS lead. So again, most of you will be non-trainees. Look for which group you belong to. Are you a group of, do you belong to the LED group? Do you belong to the SAS group? Look for a way to create leadership for yourself. So see what are your opportunities outside the training. You can look for leadership roles outside being a trainee. Just look at what's available in your particular trust. Lead on a course. Ask if you could help with simulation training. So most trusts do have simulation training for their trainees or junior doctors on a day-to-day basis, or at least on a weekly basis. See if you can join into that team, either as a co-lead or a lead if possible. And that will tick not only your leadership skills, it will also lead your teaching or simulation skills tick box. So you've ticked two tick boxes on the same thing. Mentoring, training, assessing junior colleagues. You're all going to assess junior colleagues. You're going to do assessments for them. That shows your leadership. If you mentor someone, even formally or informally, that's a form of leadership. Chairing a meeting, again, this doesn't have to be formal. You don't have to formally lead a service to chair a meeting. You could just ask, for example, it could be a weekly meeting. Maybe you're doing an endocrine rotation and they have endocrine weekly meetings or to discuss their cases. You could ask the consultant, could I please lead this meeting for today, just so I can tick off that HLO for my portfolio application. Most consultants are very flexible. They will allow you to lead that meeting and they'll support you where need be. But again, you've ticked that tick box. Leading a clinical governance activity. So when you're leading audits, when you're leading QIPs, when you're leading maybe writing up an SOP or writing up a clinical guideline, you're the lead in that particular activity. That is a leadership skill. And by doing that, you're not only ticking leadership, you're also ticking the clinical governance tick box. So you've ticked two again at the same time. So that's cross-referencing. Examination or recruitment of junior colleagues. Again, we don't all get an opportunity to do this, but if you do get an opportunity, please take up that opportunity. Now, team working, I think, is much easier. Again, this is something you do not have to think about. You're all doing it on a day-to-day basis. Just make sure you're collecting the documentation for it. Communication with colleagues. This is medical and non-medical. It could be you're discussing with your colleagues through an MDT. It could be discussion with a colleague through referral letters. It could be through emails. It could be through it could be through several. It could be a face-to-face conversation. But again, that's difficult to document. So try to use modes of communication that you can actually document and evidence. It could be non-medical staff you're communicating with. For example, it could be with your secretaries or the secretary of your consultant, where you're talking about getting advice on, can you please share this up for me? Or can you please help me get this documentation from another trust? That's all communication. It all is important. And remember, when you're talking about communication, don't just focus on health. Don't just focus about other medical teams or the therapists. Look at communication beyond the health sector, because they're trying to see that you're able to communicate as a network and not just stick to the health sector. Communication with non-health agencies. We were talking about housing and school. We've already given examples of this. For example, if you're communicating about giving a WEES plan to school, and maybe you need to communicate directly through the asthma nurses to get that across, because maybe the child is not able to share it directly with them, or you're communicating with housing. It could be several other things that you're communicating with, but just think broadly. Meetings, Naomi's already mentioned a lot of meetings. We have meetings on a day-to-day basis. It could be MDTs within a particular specialty you're rotating with. It could be strategy meetings. It could be hub meetings. It could be discharge planning meetings. All that is team working. As long as you're part of that team and working as in terms of contributing to that particular meeting, you are able to evidence that you're working within a team. But remember, try to collect minutes for this, or if they're not for formal minutes, most trusts will document on the electronic system or on paper who attended that particular meeting. So again, that can be used as evidence. It doesn't have to be formal minutes. Examples of evidence that you can use in that particular area. So again, you could use letters. It could be minutes of meetings. It could be records of MDT discussions, clinical correspondence, letters to external agencies, joint clinics, work-based assessments, and try to do at least one or two of these work-based assessments as part of your leadership evidence, because it just show that you're doing something similar to the trainees, and it often holds more weight. CPDs, again, I've collected from you some free CPDs that you can do. There's a management and leadership skills program on the ELF website, but there are some paid programs through the Royal College, which I've put there as well. But there's a Royal College Leadership Hub as well. Do some CPDs from there and do reflections on them, and there you've satisfied this particular HLO. Testimonial, this is very important. If you're doing a role that you're, for example, the SAS lead role or a BMA rep role, part of the LNC, sometimes you can't formally show how you're doing that role. So ask some of your members of that group or the lead of that group to write a testimonial for you to show what you've actually been doing in that particular role. That's may not be very well formalized. So my top tips, keep it simple. This sounds very scary, and it can be, but until you actually do it, you realize it's not as bad as it looks. And don't try to stress yourself too much to do what's already outside your role. A lot of what you're already doing is already your evidence. You just need to see it. So you need to just step back and see, what am I doing on a day-to-day basis? And what from that daily experience can I actually use as evidence? And you'll realize you already have so much evidence in your day-to-day role. Have a clear target. Set a time plan for yourself, because if you don't, you'll keep saying, I'm doing it, I'm doing it, I'm doing it, and you'll never end up doing it. And then finally you'll be like, oh my gosh, I've spent 5 years and I have to go back again, because there's a time limit to this application. So have a clear target and just get onto it. And once you're on it and you start the application, it's amazing how things just fall into place. Believe in yourself and trust your advisor. My advisor was amazing. I can't say that enough times. He was very straight to the point, very supportive, and very responsive. And I think most advisors, I hope, are like that. And I hope you get one of those, because genuinely we're very afraid of our advisors and we think, oh my gosh, they're not there to support us and they're going to be very strict. They're on the GMC's side and not ours. Actually, I don't think that's true. And I think you'll realize that once you start the process, they're actually on your side. They want you to succeed and they will help you succeed. Just take their advice and don't get discouraged, because if it's advised to get you to do more things or to collect more evidence, it's not because they're trying to make your life difficult. They're trying to make your life simpler in the long run. Because if you listen to the advice, the next hurdle will be much easier. Just remember that. If you go through if the advisor seems like a hurdle, it's because they want you to go through the Royal College assessment much, much easier. So one hurdle, it's better to have a hurdle in the beginning than at the end, is what I'd say. Okay, thank you. And I think I'm happy to go into questions.
Amazing. Thanks, Jazz. I especially love your pictures and the mama lion leading her cubs. I like that idea that the pediatric registrar or like junior consultant is in that role. Um, that was super useful because I think that leadership stuff is really quite hard, isn't it, for all of us when we're junior. As soon as you step into a senior role, then it's kind of they just expect you to do it. But when you're in the more registrar service delivery role, you can easily feel like something separate, additional. So I mean, Naomi also, potentially you could put your camera on. I know you guys were doing it kind of answering separately, but so there was a few questions that we didn't quite get to previously, and then maybe now some questions are coming in. There was a bit of talk about the 5 years and does it have to be within 5 years to give evidence, and can you count evidence from an Irish job? So I've said yes, and there was some clarification from B, so that was really helpful that the GMC have said 5 years, but you can extend it beyond 5 years for mat leave and things like that, but they don't really want it going into like 7, 8, 9, 10 years. If it's going towards 10 years, you might have to probably explain a bit more. Or they might want you to show that you've refreshed something that you did 10 years ago, that it's still current. Would you guys agree with that? Because that question came up a few times.
Yeah, absolutely. Usually within the
Oh,
last
I can't
five
hear you.
years.
You're very quiet, but maybe others can hear.
Oh, okay. So within the last five
A
years,
bit better, but can you?
ideally, within the last 5 years, ideally, I think if you go over, I think they probably accept up to 6 years. But anything beyond that, they would want you to show evidence that you have up-to-date skills within it.
Yeah. And then about health promotion, that was really helpful because obviously we do it all the time. It's hard to think of those things. They seem so obvious, don't they? But it sounds like, again, you're saying very clearly that reflection is like king. Yeah, they really, really are happy with reflections as evidence. And I think that also relates back to you even NLS and EPALs, it's not enough to put a certificate. They seem like they're not that interested. Like in other things, a certificate is enough, but actually they don't really care that much about the certificate. It seems like you're saying they actually want the reflection. That's where they feel that the value, the real evidence is. Is that right? So for like the courses and for say the vitamin K advice or the vitamins or vaccination advice, is that right? That reflection would be the main way, like is necessary for those things.
I think for certificates, I'd recommend always show that you're reflecting because anyone can do courses. You can put an online course and just not listen to anything. And that shows you've got the certificate, but you've actually listened to nothing. So if you want to make it useful, do a reflection to show that you actually gained something. In terms of the other health promotion bits, if you've got other evidence, for example, if you've got written documentation, you don't necessarily have to do a reflection. But again, it's good if you can, because it shows that triangulation of evidence and shows that you're thinking broadly and you actually understand what you're doing. You're not just taking everything from your daily practice and just putting it out there for them. You've actually reflectively thought about it. So it is good to do reflections or some sort of other evidence which shows triangulation, but it doesn't have to be done for every single thing.
Okay, great. And then there was a question about how much, I think it's about how much. It's about neonatal experience. So I'm assuming it's someone with general peds like aspiration who is asking about how much neonatal experience. And then no one's asked it, but I think I have been asked it a few times about community experience. Do you need community experience and how much? And maybe easier for Naomi. Well, I don't know, but obviously because you're in community, so it would have been no trouble for you to get those kinds of things. And I think Naomi, you had to go out, but maybe between you and Wakasa's also joined, so potentially he might have some ideas as well.
Yeah, I'm happy to answer that one. So in terms of community,
It's
you
still
don't need
very quiet. If anyone else finds it loud, put in the chat or tell me, and I'll stop bothering Naomi. But I fear that
Okay.
it's
Does it sound clearer now?
it's a bit louder though. If you just speak up loudly, we'll manage it.
Okay.
Oh, for Noha, it's clear. So maybe it might be.
Okay. All right. So in terms of community, you don't necessarily need to do a community posting. However, you need to get all the competencies related to community. And off the top of my head, and just can chip in if I miss anything, off the top of my head, you need to have experience with developmental assessments, CLAs, initial health assessments for children, SOGS assessments. Okay, that's developmental assessment, ADOS, ADHD, EHCP, all the statutory things. If you have experience in those things, and you've attended some clinics, I think that would be fine. I'll tell you what I did. So in my case, I couldn't do a community posting. So
Naomi, it sounds okay to me now that you're speaking up, but some people are saying it's not clear
it's
just
not
now.
clear.
Would you just, I think if you just speak a bit louder and maybe if those people turn up their volume,
Oh, I'm so sorry.
because I've turned my volume right up and that's helped, and you've also spoken up.
Uh,
So just carry on and keep very
So
nicely projecting because
in
it's so
my
valuable. I
case,
don't want them to miss it. Yeah.
in my case, what I did was I attended community clinics. I took study leave, attended some community clinics on my study leave days, some annual leave days, and some off days, just so I got all the experience and things that I needed. And then when they needed people to do some locum clinics, I signed up for some locum clinics, did some EHCP, some IHAs, initial health assessments, did some SOGs, and then I got all the competencies they wanted. And I'd done lots of safeguarding CP medicals and witness reports, and all that was the evidence that was required, in addition to your safeguarding level 3 training. I
That's
don't know if people heard. I'm so
DNA.
sorry if you haven't heard.
Um,
Did people hear?
well, it's here and it will be on the recording. So I'm just saying maybe people leave and come back if it's still difficult, and it will you'll hear it on the recording. So that was nice what you said. I can summarize briefly. Actually, maybe would you mind just typing them into the chat? Just
Okay. Yeah.
suggestions of these are probably
Yeah.
the bottom line things, unless
Yeah.
there's a list on the RCPCH website, which obviously is a great resource for the bottom line of like community things that you might want to do. And I'm aware that Wakas is here as well, so it might be good if we go into like the kind of general Q&A. But did you want to answer? Do you have an answer about neonates, either of you?
For the neonates, I ended up doing it again. It was getting the competencies. So I got every single competency that was requested for. And I did that through my neonatal unit. And then I went to a level 2 neonatal unit, got some competencies, and I was attending grand rounds in the tertiary neonatal unit, which I arranged.
Was that on like days off, or did they give you special
Study leave, study leave.
EDT days? Okay.
Yeah.
And you were doing a bit of shadowing, and were you actually doing so like were you working doing service delivery as well, or were you
So
supernumerary or
So in the secondary new in the level 2, it was service delivery. I did a 6 months rotation there within the same trust. And then in the level 3, it was supernumerary, where I was shadowing and joining their grand rounds and
yeah.
participating, presenting at the grand rounds and so on.
Yeah, so a very educational kind
Yeah,
of placement. You weren't
yeah,
expected, you were extra for them,
yeah,
and they were happy to let you come and learn and put you forward for kind of educational
absolutely.
opportunities like presenting and things. Okay,
Yeah.
and you didn't have to do it on your wholly in your own time, so that's really good to know, and it as it should be. Good. Okay, so should we do the big general Q&A now? Are you guys happy? Have we? Yeah. And then I'll just answer from technical point of view. So the video, we'll make the video available to people who've registered. If you can fill in, there's a post-course of feedback, just one question really, just to say, do you feel more confident or has this addressed some of your questions from the session? And then your email address so we can send you a certificate and we can share the video for people who've registered. So that's how we'll share the video, and it might be like a week or so. Yeah, and then Naomi, maybe someone was asking about your logbook. I don't know if it's okay to share a screenshot of that. It's just a Word document with tables in it, isn't it? But if you're happy to do that, we'll add it into the post-course email if you like, to save you trying to do it now or whatever. Yo, that's a good idea. I'll put the feedback form, the link here whilst you guys are talking. So whilst we wait for any questions, did you guys have any things? We've got until 2 o'clock scheduled. And Wakas, why don't you put your camera on and I will take mine off because I'm not gonna. Well, I can give you questions in the chat from the chat. So yeah, if you had any reflections just for the group. And I think people at home, why don't we try? You can put your hand up and then we can try and unmute you so that we can get more of a feeling of being all together and supporting each other. Be nice to do that if it doesn't cause chaos. Yeah, should we try and do that, faculty? Do you think it's reasonable? We'll try. And if it becomes chaotic, we'll go back to just questions in the chat. Okay, all right.
So just, can you hear me? Am I audible? Yeah,
Sorry.
that's fine. I think most of the people know me. I'm not a celebrity. So just to extend the last thing which we discussed about the competencies in community pediatrics and neonates, I assume the question is about general pediatrics. General Pediatric CESR. So yeah, as Naomi and Jazz said, there is no there's no posting or experience certificate required that you have been rotated through these specialities. But if you go through the application, that's why I always say to do collect your evidence retrospectively, start your application, and will you see what they are asking for, and you can make a table of the competencies. So whether you do a rotation or you do a community clinics in your time off, what you need to provide is few things are very important. Looked after children clinic, their initial health assessments, autism assessments, developmental disorder, autism, ADHD, complex needs, and your communication and correspondence with the allied health professionals such as speech therapists, occupational therapists, nursery, school, all where you can get the information from the about the child, a health visitor, etc. So if you think that you can collect these competencies while staying in the general pediatric ward or attending clinics in your off time, that's fine. If you think that you need to do a rotation, so that you can do that as well after collaborating, after getting an agreement from your department. For neonates, you don't need to work in a level 3 unit. You can get all the competencies which are asked in the general pediatric CESR. I'm talking about general pediatric CESR. For all the neonatal competencies you can get while working in a level 1 and level 2 neonatal unit. If you are not working in any neonatal unit at all, then probably that will be a bit difficult because you have to provide competencies for neonatal resuscitation. And many times it asks to provide evidence to manage unwell child, young person, or baby. So they use this word baby. So you have to provide all the evidence for procedures, for example, UVCs and airway management of a neonate, so which is difficult to get while working only in pediatrics. So a level 1, level 2 can cover definitely all the competencies, but level 1 can do as well. Is that okay? I hope.
And I think also you could, even though it's obviously different to training, but the trainees alongside you will be collecting these kinds of evidences as well. So they feel free, I think, to speak with them as well about how would you evidence this or that kind of thing, because actually the kind of the substance, the content is the same. It's just that they are asking you to present it a little bit differently. So let's go to the questions. I don't see any hands raised. I think you've already answered about having the 12 to 15 categories, your folders, Naomi. That was really clear, and that you would have about 10 to 15 pieces of evidence in each folder, I think.
Yeah.
Is the question was about. And then they've gone on to say the cross-reference document you add for all domains. Do you add each KSE point that the SSG set, that there's special, I can't even remember what these acronyms stand for now, and add the evidence available in domain and the cross-reference?
Yeah. So my table, and you don't have to use it, but what I found was helpful was writing out what the GMC have said they want, or the college have said they want from the specialty specific guidance, and then writing what evidence I've provided in that domain, or if I haven't provided evidence for what they want in that domain, but it's somewhere else, then I put the cross-reference as the fourth one. If we can put that presentation back on, I'm happy for that presentation to be shared with everybody who attended so they can see the table, what it looks like.
Well, that's very kind. All right. I think that would be useful. So someone's saying that they moved from Pakistan a year ago to, yes, less than a year ago. Can they use evidence of their level 1 and 2 neonates from there? So I'm going to answer that and say yes, but correct me if I'm wrong. And then can I just check something? Mostly, obviously, soft landing is targeting IMGs, but we're also, there will be some UK graduates who are looking into CESR as well. Do you have to have overseas experience? I'm not sure. Does anyone on the call? You don't have to, because there used to be a condition that you had to have 6 months overseas experience.
I have a feeling that that's for community pediatrics.
Okay, it
I
could be
have a
one of the
colleague who
specialists.
did CESR. She was a trainee and she got to ST6, and for some reason she didn't want to carry on with training and she completed CESR. She's working as a consultant, I believe, at George's also.
If someone's kind of arrived and somewhat new to the NHS and they're still thinking about training and the CESR route, would you ever recommend starting CESR, paying your money, or just maybe not paying and registering, but starting to formally collect evidence whilst you're also going through the kind of getting into training process? I know what my answer would be, but it would be useful to know what you guys think.
If I answer and then others can answer as well, I would say yes. If you're not too sure, just start gathering the evidence because you will need it for training or whichever pathway you take, you would need it anyway. So start gathering the evidence. And there's no payment for CESR until the point of submission. So if you do decide to open an application or something, which can stay open for 2 years, you don't need to make any payments. But yes, you can gather evidence because it's part of your skills progression and training as a doctor, whichever pathway you end up taking.